A nice and warm welcome to our webinar today. My name is Eric and I will guide you through this webinar. We're going to talk about the measurement of fitness to drive and driving safety with our new test set Drive Screening 2. The slides, you can download this in the webinar tool and in the end of the webinar we can talk about some questions if you have some. So today's webinar deals mainly with the meaning and the measurement of fitness to drive and driving safety. In the beginning, we're going to talk about driving as an integral part of everyday life in Western society. Then we are going to talk about the subjective and objective meaning and resource of driving, especially for older people. Then we're going to talk about some factors which can impair the fitness to drive and driving safety. And last but not least, I'm going to present you our new test set, Drive Screening 2. So driving is an inherent part of everyday life in Western society. As we can see in different statistics, cars remain a popular means of transport. There are about 1.3 automobiles per household in Austria and 1.1 automobiles per household in Germany. And also, if we look at the transport routes per workday and the means of transports, we can see that in Austria, for example, a lot of people are still going to work or somewhere else by car, 48%. There are 10% more who are car passengers, as you can see in the pie chart on the right side of the slides. There are about 21% who are pedestrians, 3% who are cyclists, and 18% are using public transport. So there are some differences in the countryside and in the cities. In the cities, more people use public transport, and on the countryside, more people use the car as a means of transport. So driving is not only an inherent part of everyday life in our society, it is also a very important resource, especially for seniors. There are very different scientific studies who showed us the subjective and objective meaning of driving. Driving, for example, is related to autonomy and independence, especially in older people. It is related to social inclusion, the quality of life, and emotional stability. I myself used to work in a geriatric rehabilitation clinic, and there were a lot of different patients, for example, with dementia, mild cognitive impairment, and stroke, and with different medication. And the question which was very important for most of the people in this hospital was if they can drive with this illness or with this medication. So the mobility in the old age becomes increasingly important in a society that is living longer. There are a lot of statistical predictions which show us the alteration of the population's age structure. So on the left side you can see the age structure in Germany in the year 2018. There are a lot of people who are approximately 55 years old. There are some young people and some old people. But if we look further in the future, in the year 2040, there will be even more old people. Most of the people will be around 75 years old. So mobility for these people gets even more important. And because there are more old people, it is getting increasingly important for our society. Unimpaired cognitive functions are important for safe driving. There's a lot of scientific literature on this issue, and if we take a closer look at the literature, we can see that there are three especially important dimensions for fitness to drive and driving safety. One of them is attention. So if I'm on the road, I have to attend to different cues. I have to look at the traffic lights, have to look at pedestrians and at other cars, and I have to focus on these different kinds of information. Then, of course, the executive functions are very important. I have to be cognitive flexible. I have to adapt to new information, and also the visual spatial perception is important as well. But there are actually various factors that can impair the cognitive dimensions which are relevant for driving safety and fitness to drive. Cognitive impairments occur in neurological and psychiatric disorders and during drug treatment, for example. So, as I said, when I was working in the hospital and there were these people who had these kind of disorders, it was not very sure if they can drive or if they cannot drive. And this question is particularly important because depending on the disorder and medication, the impairments turn out to be heterogeneous. This can be illustrated by the case of painkillers. Here you can see an illustration from a meta-analysis which investigated the relations between driving safety and drug treatment with painkillers. And as we can see in this illustration, the relation between these variables is very heterogeneous. So there are some studies which show, yes, there is clearly a higher risk if you take painkillers for the driving safety, and there are some studies which are not so clear. So the point is here that an individual diagnostic clarification is necessary. And here our new test set comes in, the test set DRIVESC2. It is a short screening instrument to measure fitness to drive and driving safety. The dimensions which we are assessing here is information processing speed, cognitive flexibility, and the visual orientation ability. The duration, of course, is quite short because it's a screening instrument, so it's approximately 2 to 7 minutes. There's an index value which gives an overview of the TMTL results. There's a word report, supervisor supported testing is possible, and DRIVESC2 is also touchscreen compatible. We also have a representative norm sample from 16 to 86 years. So when we developed this test set, we wanted to focus on the cognitive dimensions which are particularly relevant for fitness to drive and driving safety. So we took a look at the scientific literature and identified these 3 dimensions. As I said before, these are attention, executive functions, and visual spatial perception. The test starts with the first part of the trail making test, which measures processing speed, which is a subdimension of attention. The duration is quite short, it's only 1 minute long, and the task is to connect the numbers like from 1 to 2, 2 to 3, 3 to 4, and so on. And this information processing speed is particularly important for action planning on the road. So for example, if I'm driving and I see the traffic light is turning red or turning yellow, I have to process this information and react to it. Then the test continues with the second part of the trail making test, which measures cognitive flexibility. Cognitive flexibility is a subdimension of executive functions. The duration here is quite short as well, with 1 minute, and the task is a little bit different. So as you can see on the right side, we don't only have numbers right here, there are also letters, and I have connect the numbers with the letters, and then the second number, then the second letter, and so on. So for example, 1, A, 2, B, 3, C. So this is a new task, and the patient has to adapt to the situation. And this is relevant for handling of unforeseen situations. For example, if I want to turn right and the traffic light is green, and then I see that there's a cyclist going very, very fast and he wants to pass me, then I have to adapt to this new situation. And this is why we are measuring cognitive flexibility right here. The add-on test, the line orientation test, measures visual orientation ability. This is a subdimension of visual spatial perception. The duration right here is around 5 minutes long, and as you can see on the right side of the slide, the patient gets 2 arrows presented and he has to click on the numbers which he thinks these arrows point to. This is especially relevant for dealing with disruption of targets on the road. The test set DRIVESC2 can be administered in various formats. On the one hand, you can administer it on the laptop or on the PC, and it's possible to do this with standard instructions, so the patient can work on his or her own, and with supervisor-supported instruction if the patient needs some support. And this is not only possible on a laptop or on a computer, it's also possible on touchscreen devices. So when the testing is finished, the results are concisely presented within a table and profile. As said before, there is an index value, the DRIVESC2 index value, which is a good overview for physicians, relatives, or patients, and this index value is consisting of weighted TMTL results. So we took a look at the scientific literature and we weighted these variables based on meta-analysis, so the result is able to predict fitness to drive and driving safety as good as possible. A little bit lower you can see the main variables per subdimension. Here we have some more specific information concerning the dimensions, and we also have a traffic light system to easily identify potential impairments. If I have a percentile rank above 15, this would be green, a clinical normal result. From 4 to 15 is an indication for a mild cognitive impairment, and below 4 would be an indication of a severe cognitive impairment. So of course this is only a screening tool, but if I have yellow or red results, this is a good indication that some further diagnostic clarification is necessary. And below we can find the profile display. So we don't only have this kind of presentation of results, we also have an extensive and concise word report. On the first page you can fill in some general information, for example the case history or psychopathological findings. On the second page we got some more information about the interpretation of the results. Then we have a summary of test results, and last but not least there is the interpretation of the results with some explanation what the different dimensions and values mean. Of course we also checked the psychometric quality criteria of the DRIVESC2 and they are fulfilled. The objectivity of administration, scoring and interpretation is given by the standardized and computerized administration, the automated scoring and the given norm values, which makes interpretation easy. Reliability is also given. We check the Cronbach's alpha and the greatest lower bound, which is a more modern type of reliability, and the reliability is sufficient. Of course, we also took a look at the validity. We examined the construct validity by confirmatory factor analysis concerning the TMT and by relations to constructs which are close or distant to the proposed dimension which we want to measure. In case of the LUT, we checked this by the multi-trait, multi-method approach, which you probably know by Campbell and Fiske. Noteworthy is here that the relations between the test paradigms and driving behavior are shown in various scientific studies. So we're talking about criterion-related validity here. Various studies show that the tests of DRIVESC2 are linked to performances in driving tests, to safety-related mistakes, to navigation performance in clinical and also in non-clinical samples. Because here at SCHUHFRIED we value scientific research, this test set DRIVESC2 is currently being validated in an additional study as well. The research question right here is the DRIVESC2 able to predict the fitness to drive in cognitive impaired persons? Here we have a well-known cooperation partner, Dr. Brunauer from the University of Munich. And we are looking at healthy persons in the control group and cognitive impaired persons in the experimental group, and they do some testing with the tests of DRIVESC2, but also with the test set Cognitive Functions Dementia, which we developed here at SCHUHFRIED as well, and also the well-known Mini-Mental Status test and the clock drawing test. And we are going to check which of these tests and variables are able to predict the results of a standardized driving test, the Wasserburger driving behavior test. So to summarize this webinar, why should I even choose the test set DRIVESC2? The test set is relevant. Driving is an important objective and subjective resource. It is flexible. It is possible to administer it in different formats, for example in touchscreen or normal computer. It's very economic. The test duration is short and the scoring is automatic. It is objective. The scoring is unambiguous, differentiated and not error prone. The test set is valid as we've seen numerous scientific studies show concise relations of the tests with driving behavior, and of course, because it's a computerized test, the DRIVESC2 is eco-friendly. The paper consumption is minimal.